Hi, my name is Jason Gotlib, and I'm a professor of medicine at the Stanford Cancer Institute in Stanford, California. And I want to thank the organizers of SOHO, Saudi Arabia for inviting me to talk about updates in eosinophilia for 2023. These are my disclosures. So when I do a workup for eosinophilia, the first thing I do is, of course, rule out reactive causes or secondary causes, which is usually the purview of internal medicine docs or other subspecialists. If such causes have been excluded, then I'll do a workup that focuses on primary or clonal causes of hypereosinophilia with some of the peripheral blood and bone marrow cytogenetic or NGS or FISH tests as shown in the central box there. And I use this data to basically stratify patients to different clinical boxes of potential diagnoses. The first on the left would be myeloid/lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions. Also, who define myeloid neoplasms associated with eosinophilia, such as, for example, chronic myeloid leukemia, systemic mastocytosis, or myelodysplastic neoplasms. Another entity is chronic eosinophilic leukemia, which I'll discuss further, of course, during this talk, which these days is now more focused on bone marrow morphology, in addition to the possibility of finding a clonal molecular or cytogenetic abnormality. And then I'll briefly touch on lymphocyte variant hypereosinophilia. And if none of these entities are present, then one may reach a diagnosis of idiopathic hypereosinophilic syndrome if there is organ damage thought to be mediated by the eosinophils. Now, the 2022 International Consensus Classification, or ICC, categorization of primary eosinophilic neoplasms is shown here, included within the MPNs. And for example, they include chronic eosinophilic leukemia, not otherwise specified, and also these myeloid lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions. In the workup of eosinophilia, one depends on tests from the peripheral blood, bone marrow, and also potential evaluation of organ involvement, for example, by imaging such as echo or ultrasound or CT MRI, endoscopy to look for eosinophils in the lining of the gut, or organ-directed biopsy, for example, of the liver. In the peripheral blood, we depend, of course, on traditional testing such as the CBC, looking at the smear, chemistries and liver tests, serum tryptase level, for example, in particular looking for mast cell disease. We also want to look at specific molecular abnormalities such as BCR-ABL1, JAK2, KIT, fusion genes that are involved in myeloid lymphoid neoplasms with eosinophilia, NGS myeloid mutation panels, and of course T-cell clonality to look to see if there's a T-cell driven process such as seen as lymphocyte variant hypereosinophilia. Now let's first focus on this category of myeloid lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions. Now, in prior classifications from the World Health Organization, these included fusions involving platelet-derived growth factor receptor alpha, platelet-derived growth factor receptor beta, and FGFR1, and the provisional entity PCM1 JAK2. But now in 2022, all JAK2 fusions are included, as well as fusions involving FLT3 and the ETV6 ABL1 fusion. Now, it's very important to note that not all fusions are associated with eosinophilia, so it's not something you depend on, but can be a pre-diagnostic checkpoint to think about these disorders. These diseases can present in chronic phase or blast phase disease and also include an extramedullary disease or EMD. And their natural history, as I will allude to, can be very variable depending on the fusion partners of a particular fusion gene and, of course, the particular tyrosine kinase that's involved. Now, there are so-called different flavors of presentations of the diseases. For example, one can present with only bone marrow peripheral blood disease in chronic phase of a myeloid neoplasm. One can involve a chronic myeloid neoplasm with extramedullary disease or EMD. One can include blast phase disease only in the bone marrow or including the EMD. And one can present with only EMD only. Also, there might be patients who you see who have been previously treated, and they may only have cytogenetic or FISH evidence or molecular evidence of an FGFR1 rearrangement or other tyrosine kinase gene that's involved in these diseases. Now, these are the different tyrosine kinase gene fusions, and their partners. You can see that for PDGFR alpha, there's some 8 genes that have been partnered with PDGFR alpha. For PDGFR beta, there's over 30. For FGFR1, there's 16. For JAK2, there's 3. For FLT3, there's around 7. And then, of course, there's the ETV6 ABL1 gene fusion. And you can also see that now there are FDA approvals for imatinib for PDGFR alpha and PDGFR beta rearranged disease. And last year, we had the approval of the FGFR1 to 3 inhibitor, pemigatinib, for patients with rearrangements involving FGFR1. And I will talk about some of that data, which is more new. Now, with regard to FIP1L1 PDGFR alpha disease, this is exquisitely sensitive to imatinib, usually at doses of 100 milligrams per day, doses that are lower than that used for chronic myeloid leukemia. And you can see that the complete hematologic remissions, or CHR, and complete molecular remission rates are basically approaching 95 to 100%, and there are very rare cases of resistance or deaths, particularly in chronic phase of the disease. Now, it should be noted that this is an agent imatinib that is, of course, used for chronic phase disease, but we see very good results with blast phase disease. The inclination is for such patients to consider using multi-agent intensive induction chemotherapy, but one may just consider imatinib with very good durable results. In some cases, for example, for resistance relapse, of course, the use of induction chemotherapy as a bridge to transplant may be considered, but one may consider starting just with imatinib in patients with advanced disease. Now, there are rare cases where imatinib resistance occurs. It's very uncommon, and the canonical 2 mutations that we see in resistant disease is T674I and D842V. I would say that still in 2023, we have trouble identifying a tyrosine kinase inhibitor that can solve these cases, but with the approval of avapritinib for D842V mutated GIST tumors, there may be an opportunity to use that agent for patients with that mutation in the context of this disease. Ultimately, these are patients who will need to go to transplant for any chance of cure. Now, in other ML and EOs, myeloid lymphoid neoplasms with eosinophilia, for example, those with a JAK2 rearrangement, one may consider using a JAK inhibitor such as ruxolitinib. One may get clinical or hematologic responses, even cytogenetic responses, but they do tend to be transient, and ultimately these are patients that if one is using ruxolitinib likely need to be bridged to an allogeneic hematopoietic stem cell transplant. Now, this is a patient that I'm actively treating now at Stanford who has an ETV6 FLT3 fusion. This is a 78-year-old woman who had diagnosis. You can see the PET scan on the left had substantial extramedullary disease and bulky lymph nodes. At diagnosis, her FLT3 arrangement was found in 91% of cells. And after several months of gilteritinib, a potent FLT3 inhibitor, dose reduced because of neutropenia to 40 milligrams per day, you can see that the on-treatment PET scan shows essentially complete remission by imaging, and her FLT3 arrangement by FISH is now negative, and she's really enjoying a good response to gilteritinib. Now, going to pemigatinib, which is, again, more recently approved for FGFR1 rearranged disease. The approval was based on the FIGHT 203 study, and these are patients who are treated first 3 weeks on and 1 week off, but now there is continuous dosing, and the primary endpoints were complete clinical remission and also complete cytogenetic response rate. Now, in these patients, and again, these patients present a chronic phase disease or blast phase disease, sometimes mixed phenotype acute leukemia. You can see that the complete clinical response rates were in the order of 60 to 70%, more robust, admittedly, in chronic phase disease, but also you have very good complete cytogenetic response rates, again, higher in chronic phase disease, but totaling in the range of 70 to 80%. So very robust responses, including very good cytogenetic responses with pemigatinib. And really, there's not been a very good agent for FGFR1 rearranged disease. Some people have used asatinib or ponatinib, but such agents, including also chemotherapy, really have not shown to be effective in this disorder, which has a high rate of evolution to acute leukemia if presenting in the chronic phase. This is a swimmer's plot showing that the responses, at least in chronic phase disease, are quite durable. I would say that if one were to examine the durability responses in blast phase disease, you're getting deep responses, but they are not as durable as they are in chronic phase disease. So the summary of the Fight 203 trial showed, again, high rates of clinical and cytogenetic responses, and these are patients who, for the most part, had at least one prior treatment. Again, the responses in blast phase disease are less durable. Having said that, a fair amount of patients on study, whether it be chronic phase disease or including blast phase disease, were uh, transitioned to transplant, and pemigatinib was used as a bridge in that regard. This is a drug that can include some side effects, including hyperphosphatemia, alopecia, diarrhea, and stomatitis. So with prolonged therapy, there are patients that do need to be dose reduced from the starting dose of 13.5 milligrams daily, for example, down to 9 milligrams or even 4.5 milligrams, to try to achieve that balance of both efficacy and tolerability. And again, as I mentioned, this is a drug that I don't personally think is something that one would likely use for years and years, but if there's a transplant option, I see it most notably used as a bridge for patients that have a suitable donor and are eligible for a transplant. So again, this drug was approved, is now available, at least in the United States, for FGFR1 rearranged disease in patients who have received one prior therapy. Now, if I was to summarize the MLA and EOs, I would say that the best prognosis are those in patients that have a PGFR alpha or PGFR beta fusion because of very good responses to imatinib. And patients can use imatinib on a maintenance regimen, and for example, 100 milligrams, maybe even just 3 times per week. Resistance is very rare. And for those patients that have an ETB681 fusion, it's felt that second generation tyrosine kinase inhibitors, such as nilotinib or dasatinib, are more potent than the use of imatinib in that disorder. For patients with FLT3, JAK2, FGFR1 rearrangements, these historically have had worse prognosis. But now, for example, with pemigatinib, that natural history may be changing, but ultimately, a transplant needs to be in the thought process regarding where these patients are ultimately situated, because even with TKIs, the responses are not necessarily going to be very durable. There might be some exceptions, but one can't necessarily count on that. Okay, how about I pivot to chronic eosinophilic leukemia? You can see on the left the international consensus classification, on the right the WHO diagnostic criteria. The bottom line for CEL is that these are patients that have at least absolute eosinophil count of 1,500 or greater in the peripheral blood, that they have less than 20% blasts, they don't be labeled with acute leukemia. One has to exclude other canonical fusions such as B-cerebral-1 or the fusions I mentioned of myeloid and lymphoid neoplasms with eosinophilia. They can't meet criteria for another WHO diagnosis such as CMML. The bone marrow is placed more prominently in the diagnosis of CEL in both the ICC and WHO classifications, in that the bone marrow usually shows dysplastic morphology, particularly the megakaryocytes, and there may be dysplasia of the other cell lines, and often one sees fibrosis. And then also importantly, there is almost always a clonal, cytogenetic, or molecular abnormality, but if there isn't one present, then one needs to depend on the bone marrow morphology with its dysplastic morphology to try to make a determination whether this is more likely chronic eosinophilic leukemia rather than, for example, idiopathic hypereosinophilic syndrome. Now, it's notable that patients who were at least historically considered hypereosinophilic syndrome, when one has done NGS testing, in some patients at least, one can identify myeloid-type mutations, but one must also be careful to always attribute such mutations to the pathogenesis of the chronic eosinophilic leukemia, because some mutations can be CHIP mutations and may not be relevant actually or disease causative. Having said that, if you look at the survival curves of patients with hypereosinophilic syndrome, they typically do better than those with, if you have HES without a mutation, those patients do better than those patients that were HES who were subsequently found to have a mutation in a myeloid gene or were, for other reasons, diagnosed as chronic eosinophilic leukemia. Now, there are studies, for example, from the German registry that shows that when you evaluate people with idiopathic hypereosinophilia or hypereosinophilic syndrome, there are a proportion of patients in which one can unmask, for example, the FIP1L1 PGFR alpha fusion or a JAK2 mutation or a KIT mutation. If one finds a KIT mutation, these are patients who almost always have a diagnosis of systemic mastocytosis. And you can see here that patients with FIP1L1 PTR alpha have a very strong male predominance. They are the patients among these three types of different mutations that have the most prominent eosinophilia, but those patients with mast cell disease have the highest tryptase levels. And you can see here that patients with FIP1L1 PTR alpha on the right enjoy the greatest survival because of the use of imatinib now, whereas those with the JAK mutation or KIT mutation enjoy a relatively worse survival because of natural histories of those MPNs or mast cell disease. We also have seen mutations in STAT3 or STAT5B in a low proportion of patients with eosinophilia. That's important because such patients may ultimately be targetable, for example, by a JAK inhibitor, which targets a JAK-STAT signaling axis. Now, there are two case series, albeit small in number, from Poland and from Mayo Clinic in Rochester, which show that the natural history and prognosis of CEL is generally poor, with median survivals of about 1.5 to 2 years and a fairly high frequency of evolution to acute myeloid leukemia. Hydrea or imatinib, if one can consider that really a viable therapy in this disease, have been used, but generally are not very effective. Ultimately, these are patients, again, that may need to go to transplant. I would say also that hypomethylating agents such as azacitidine or decitabine may be used because some of these patients have dysplastic morphology of the bone marrow, so one may co-opt HMA therapy for CEL because of the overlap with MDS. So again, if one can find a target, one could consider, for example, a JAK inhibitor. Conventional therapies have included hydroxyurea, interferon alpha, or imatinib, although again, I think that most responses with use of imatinib really reflect nonspecific myelosuppression, and again, hypomethylating agents because of the overlap with MDS MPNs. In the absence of those therapies being available or effective, one could consider transplant, or of course, putting patients on a clinical trial. Now, just briefly, lymphocyte variant hypereosinophilia reflects both kind of a clonal and reactive disease. There's a clonal population of T lymphocytes. These lymphocytes are abnormal by flow immunophenotyping. For example, they may have double negative immature T cells that are CD4 negative, CD8 negative, but CD3 positive, or have absence of CD3 or absence of CD7. These patients typically have a benign course, typically present with skin disease, and what's driving their eosinophilia is that these abnormal T lymphocytes secrete eosinophilic cytokines such as IL-3, IL-5, and GM-CSF to produce the eosinophilia. Very uncommonly, but we certainly see it, these are patients that can evolve to T-cell lymphoma and Sézary syndrome, which of course is more aggressive and requires another more aggressive form of treatment. Regarding other potential therapies for eosinophilia, is because there is found to be in subset of patients JAK-STAT signaling, ruxolitinib is in clinical trials. I will talk briefly about mepolizumab and benralizumab, and there are other agents that have been used that really haven't gone forward, such as inhibitory receptor signaling, using agents against cyclic 8, for example, AK002, but that is not moving forward. And historically, alemtuzumab has been used, but that is also not commonly employed, in part because of issues of immunosuppression and toxicity. Mepolizumab is an anti-IL-5 antibody. There was a phase 2 study that evaluated the drug in patients with idiopathic hyperphilic syndrome. Basically, that study showed that mepolizumab was able to achieve reductions in the use of prednisone, both in the short term and long term. Based on that 2008 study, I guess there was some surprise that it was not approved, but ultimately a phase 3 study was done where patients on therapy were randomized to either mepolizumab or placebo, and the primary endpoint was a proportion of patients who had reduction of flares from their eosinophilia. And you can see that in patients on mepolizumab, they had a 50 to 66% reduction in flares or annualized rates of flares. And this was the basis of mepolizumab's approval in 2020 by the FDA. Now, benralizumab is an anti-IL-5 receptor antibody. This was a small phase 2 study conducted by Amy Klein and colleagues from the NIH, and you can see that the majority of patients had very nice reductions of eosinophil counts, which were sustained. And you can see that there are patients that have JAK2 mutation, these are patients that typically do not respond to benralizumab, as these patients have more of a myeloproliferative variant of hypereosinophilic syndrome. So just a word about general considerations about therapy. It is really difficult to predict what duration severe eosinophilia will cause tissue damage. There really is inadequate data to exist a specific threshold for initiating therapy, but having said that, some individuals will use absolute eosinophil count of 1,500 to 2,000. If one has organ damage, for example, of the heart or lungs related to the eosinophil count, that is certainly a reason to initiate treatment. And for those patients that have a rearrangement of platelet-derived growth factor receptor alpha or beta, because patients do so well, and we know that the morbidity of this disease over time is quite severe, these are patients that even in the absence of organ damage, we recommend treatment with imatinib, given its good tolerability and its ability to induce complete molecular remissions. So this is basically kind of some basic pearls for eosinophilia treatment. If you look at eosinophilia-directed therapy according to the type of eosinophilic syndrome, if you have a WHO-defined myeloid neoplasm, for example, CML, MDS, or mast cell disease, of course, treat the underlying neoplasm. If you have a fusion tyrosine kinase gene associated with eosinophilia, then you treat that specific subtype. For example, you have a JAK2 rearrangement, use a JAK inhibitor. You have a FGFR rearrangement, you can use pemigatinib. PGFR alpha, PGFR beta, you can use imatinib. For CEL, one can start with hydroxyurea or interferon or a hypomethylating agent. I really don't think there's a substantial role of imatinib, but ultimately these are patients that may be considered for clinical trials or transplant. For lymphocyte variant, steroids are typically frontline. Mepolizumab or benralizumab on trial have been used. And then finally for HES, steroids, hydrea, or interferon, but now we have mepolizumab can be used frontline, and again, clinical trials or transplant for advanced patients. So to summarize, I would say that the WHO and ICC classifications provide a semi-molecular categorization of eosinophilias, which also guide treatment options. And for myeloid lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions, the prognosis is variable, but now we have more targeted agents. And I think that those agents are very useful for bridging patients to transplant if that is an option. I think that next generation sequencing is very important for identifying targetable genes. And then finally, we now have a class of drugs targeting the interleukin-5 or interleukin-5 receptor axis. And these are drugs that can be very effective, for example, in hypereosinophilic syndrome. And benralizumab is now in phase 3 testing, and it's quite possible that in the next few years it will also receive regulatory approval. So with that, I'd like to thank you for your time, and I'd be happy to answer any questions. Thank you very much.